Hello, happy Friday. Welcome to everyone who's on the line. I'm Rachel Gage. I'm a nurse practitioner in palliative care here to welcome Dr. Alana Brown. She's an associate professor of psychiatry at Harvard Medical School and the immediate past chief of division of psychosocial oncology at the Dana-Farber Cancer Institute. One fun fact about Alana is that her honeymoon was a camping trip in Polar Bear County. Very exciting. We have to ask her questions about this at the end because it's very intriguing. And for those who are present at the AHPM in Montreal, she was one of the cannabis presenters. Alana was described by Mary Buss as a superb content expert in this field. So we are so lucky to have you and welcome. I'll give you the floor, Alana.
Okay, so there we go. We're now at the beginning. Okay, so it's a pleasure to be here. Thank you to Marty and Rachel for inviting me. Today I'm going to discuss the legal landscape for medicinal cannabis and the clinical and research implications in oncology. So by way of disclosures, I participated in bench research that was funded through a structured research agreement between a pharmaceutical company and the Brigham and Women's Hospital. And I'm hoping that through this presentation, you as learners will grasp even more than you already do about the evolution in the United States legal climate regarding cannabis, the scientific evidence evaluating oncologic cannabis's utility, and the medical community's approach to cannabis therapeutics. So let's begin with the evolution in the legal climate. The key takeaways here are that federal and state cannabis laws frequently conflict, and this divide influences cannabis research and clinical care, leaving medicinal cannabis something of a conundrum for patients and families, as well as researchers and clinicians. So this is my homegrown schematic intended to depict how I view the evolution in United States federal and state law regarding medicinal cannabis over time. And as you can see, in the early 1900s, they actually agreed in a permissive stance towards medicinal cannabis. But in the late 1930s, early 1940s, state law led the way towards greater restriction, and then that caused both state and federal laws to yaw sharply in their course, ushering in 5 decades of prohibition. And now state law is beginning again to lead the way towards greater permissiveness, and federal law is beginning to follow. But as you can see, there's still a significant delta between the two, perhaps the biggest delta of all time, actually. Okay, so let's go into more detail. In the early 20th century, cannabis existed in the U.S. pharmacopoeia and in patented formulas for analgesics, antispasmodics, sedatives from makers like Eli Lilly and others we still know today. But in the 1930s, 2 men, Harry Jacob Anslinger and William Randolph Hearst, you probably know as the media magnate, and Harry Jacob Anslinger was the first Bureau of Narcotics chief. They paired up to launch a media campaign linking cannabis to insanity and criminality. Now, why would they do this? Well, there probably are 2 reasons in retrospect. One is timber interest, because hemp was a major competitor to wood pulp in the making of paper. And the other may have been frank xenophobia. There was a Mexican Civil War. Mexicans were flooding across the border. And this is when the word marijuana came into the United States lexicon. It literally was a made-up word to link cannabis use to Mexican immigrants. But anyways, this is a very effective campaign, and several states began to restrict cannabis, leading to this sharp inflection point. And in 1937, here's that new word, the Marijuana Tax Act was proposed and passed, interestingly, against American Medical Association opposition. AMA at the same time was lobbying Congress for more cannabinoid research. Even as this happened in the US, the globe was interested in endocannabinoids and cannabinoids. And so in 1968, in reaction, the United States government elected the University of Mississippi to be the official federal grower of cannabis for research purposes, and it remains the only federal grower still today. In 1970, the Controlled Substance Act passed. This rendered cannabis Schedule I and cocaine Schedule II. So Schedule I means not acceptable for any medical use and with a high abuse potential. So the act viewed cannabis as more dangerous than cocaine, which is not what I think we think of today. Because I come from an oncologic institution, I will add that in the early 1980s, dronabinol, which is synthetic THC, was tested and FDA approved for cancer-related nausea and vomiting. And we get to this next inflection point. In 1996, responding to its constituency, California legalizes medicinal cannabis. And as we know, many states follow suit. By 2012, there were 18 medicinal cannabis laws on the books. And in this year, 2 states, Colorado and Washington, legalized cannabis for adult use. So you can think of this as recreational use, but that's fallen out of favor. So we say adult use. Between 2017 and 2019, 2 things happened. First, the first herbal cannabinoid is FDA approved and rescheduled, and that is a CBD medicine. And the second is that the Farm Bill of that year explicitly legalizes cultivation and sale of high-dose CBD, which is extremely low in THC. However, federal, state, and local regulatory uncertainties persist, even with this Farm Bill. And why? Well, there are many reasons, but one is most commercially available THC assays just measure yes, no, is there THC in the sample? So they don't measure whether it's less than 0.3%. So your patients may be using CBD and look like they're using THC. This brings us to almost today. I don't know why it says 2022, but okay, let's say 2023. There are 37 comprehensive medicinal cannabis laws on the books. 18 of those 37 states have in parallel adult use cannabis laws on their books. What's perhaps lesser appreciated is that 11 additional states in the United States have more limited medicinal cannabis legislation, perhaps high CBD, low THC laws, which means that today there are only 2 states that have no form of public access to medicinal cannabis, and those are Idaho and Nebraska. Okay, so let's talk about what I mean by comprehensive medicinal cannabis law. These laws offer protection against criminal penalties on the state level, allow a variety of strains and products to be sold, and allow for non-oral use. And they're structured as followed. They tend to identify qualifying conditions, so conditions that are appropriate for medicinal cannabis. They allow for recommendations, but not prescriptions to be issued. So we have to sort of change our lexicon, and that is intended to protect clinicians from federal legal exposure. So there are many intervening steps between when we suggest cannabis and a patient actually procures it. They stipulate permissible amounts that ranges dramatically from state to state, from like 2 milligrams to 24 milligrams. They establish state registries, authorize dispensary systems. And as I mentioned, they allow for qualifying conditions, which vary dramatically also from state to state, with 2 standouts. HIV, AIDS, and cancer are basically permissible in every state. So you can almost think of these laws as HIV, AIDS, cancer laws. Okay, we move on to the typical medicinal cannabis dispensary. It allows non-pharmaceutical preparations, which means not of a chemical purity standard to ensure stability, safety, or efficacy as if it existed in a pharmacopoeia. They are highly regulated in many ways, but often unregulated important ones, like ratios of active ingredients, potencies, types of products they sell, so they are sensitive to market pressure. And it's a little bit of a whole new world for traditional prescribers in that it is likely to be a non-medical intermediary in many states who ultimately advises patients on products, delivery methods, and dosing. Let's reflect on some of the differences between a traditional prescription and a medicinal cannabis recommendation. When we issue a prescription, we stipulate the active ingredient. We don't do that with a medicinal cannabis recommendation. Why? Because cannabis has more than 300 active ingredients, not just cannabinoids, but also phenols and terpenes. And so we're basically allowing our patients to access any sort of ratio of these 300 active ingredients. You do tend to in most states, stipulate the medical condition, the quantity, and the duration, but things like route, dose, and frequency are often not stipulated and will be decided by the patient or in conjunction with the dispensary personnel, or you, or but it's not stipulated. So the Schedule I designation, I know from personal experience, poses challenges to the researcher in terms of accessing federal funding. It's much easier to get a grant funded that is looking at the risks than the benefits. Difficulty sourcing study drug, as I said, there's one field in Mississippi, negotiating red tape, and you take on a degree of personal, financial, and criminal liability when you do this work. Okay, so we now move on to the science, and here are the key takeaways. Bioactivity comparisons between THC and whole plant cannabis are purely speculative. Why? Because of that reason I mentioned before. Cannabis isn't THC. It's 300 active ingredients that work through complicated synergistic and inhibitory interactions that we call entourage effects. While myriad modes of cannabis administration exist, clinical trials in oncology, so I'm approaching this from an oncologic angle, have relied mainly on oral and sublingual routes of administration. Evidence for use of cannabis for pain in cancer patients is limited. Evidence for use of cannabis for refractory chemotherapy-induced nausea and vomiting is stronger. So, Delta-9 THC, the infamous, it's the principal ingredient, it's mind-altering, it's also known to have analgesic, antiemetic, appetite-stimulating, in the Petri dish, anti-neoplastic, and anti-inflammatory effects. Common risks include abdominal pain, nausea and vomiting, dizziness, abnormal thinking, and somnolence. And CBD, which is typically the second most plentiful ingredient in cannabis. It's FDA approved for some forms of pediatric epilepsy now. And it's known to have anxiolytic effects through the 5-HT1A receptor, antipsychotic effects, so it can improve the paranoia of THC, for instance. Antidepressive, sedative, anticonvulsive, antiemetic, anti-inflammatory, analgesic, anti-craving, and again, anti-neoplastic effects in the Petri dish. And common risks, which I just lifted from the package insert, include somnolence, decreased appetite, diarrhea, transaminase elevations. This happens in 2/3 of chronic pediatric users. 1/3 improve on their own. The other definitely improves when you stop the medicine, so fully reversible. Malaise, asthenia, rash, sleep disturbance, and infection. We know that CBD is an immune modulator, and the infection risk does seem to be real. Okay, and now we move on to modes of administration, the ways our patients are using cannabis. So they are smoking it with immediate onset of action, but also theoretical exposure to carcinogens and toxins. They are dabbing it, which is using like a device to heat it very high, and it leads again to near immediate onset of action, exposure to carcinogens and toxins, and also high potency products, so they can get very sort of obtunded or high. They are vaporizing dried flower with near immediate onset of effect, but we're not heating the product as high anymore, so maybe fungal infection risk. They are vaping concentrates and distillates. A few years ago, there was a light shone on vaping-associated lung injury, which we now know is likely due to vitamin E acetate, which was used to fine-tune the viscosity of these products. So I'm hoping that the vitamin E acetate has been removed from formal sources of cannabis products, but maybe not informal ones. They are using it sublingually, which avoids smoke and may circumvent first-pass metabolism. They're using it orally, which means no smoke at all, but then you run into variable onset of action problems. So Mrs. Smith in her 80s may eat one gummy for pain and 2 hours later not feel better and eat 2 more and then find herself obtunded. They're using it topically. I don't know that it works. And research our group has completed suggests that not infrequently they're using it as a rectal suppository. And I also want to spend a moment reflecting on all the ways our patients access cannabinoids, like the whole sort of landscape. So there are synthetic cannabinoids like dronabinol or nabilone, which are FDA approved for chemotherapy-induced nausea and vomiting, and dronabinol for HIV wasting, available at the pharmacy. As I mentioned, there's an herbal CBD drug now available at the pharmacy. Just across our border in Canada and in many first world nations, there's a sublingual metered dose spray called Nabiximols. It's got a 1-to-1 ratio of CBD and THC, and it is approved in many countries for MS symptoms and for pain, particularly neuropathic. And in Canada, it's also approved for cancer pain. And then everything in mossy green, that's what's available at our dispensaries. Maybe some of it is pretty purified THC and CBD, but the vast majority of it is this unrefined full spectrum cannabis with hundreds of active ingredients. And that's what I'm going to focus my science on. And I'll leave it to you to be the judge of utility. So when I think about the evidence that we as providers hold dearest, it's clinical trials of our agent of interest in our population of interest. So I'm going to look at now at clinical trials of cannabis in cancer patients. And on the left is the full list of potential indications that I'll cover in this lecture, and on the right are the hits that we actually get. So there is research and no evidence of effect in anorexia, cachexia, low mood, and quality of life in cancer patients. There is weak evidence of effect for cancer-related pain and stronger for chemotherapy-induced nausea and vomiting in refractory cases. As I mentioned, there are many ways our patients are using cannabis, and I want to point out that most of this research has been carried out in oral and sublingual routes of administration. So there's a lot of work yet to be done. Okay, so anorexia, cachexia, and advanced cancer. This was a multi-center, randomized, double-blind, placebo-controlled trial. It's got 3 arms. It was a cannabis arm, a THC arm, and a placebo arm. And there was a high dropout rate. By the time the 243 started, 163 completed, and an intent to treat analysis showed no difference in quality of life, appetite, mood, and nausea. It was the cannabis was well tolerated, but associated with a higher hazard ratio than placebo for adverse events like nausea, fatigue, and pain. Refractory chemotherapy-induced nausea and vomiting, a more recent study. This was a multi-center randomized double-blind placebo-controlled crossover trial, 2 arms, a cannabis arm and a placebo arm. There was not a high dropout rate, and they found that there was a complete response with active drug in a quarter of cases versus only 14% with the placebo. And remember, this was a crossover study, so a third reported experiencing additional side effects when they got the active drug, but 80% preferred cannabis to placebo. Opioid-resistant cancer pain. I'm going to just summarize this literature. So there were some early small trials that these were done with Nabiximols, that 1-to-1 sublingual metered dose spray. Early trials suggest that the Nabiximol is twice as likely as placebo to lead to a 30% pain reduction. And I know you're a palliative care audience, so you will know that that's a huge reduction in pain. However, Nabiximols failed to meet primary endpoints in 3 large clinical trials to follow. It was deemed to be safe and effective by some secondary measures, but our FDA did not approve it for cancer-related pain. So now I'm going to broaden the pyramid of acceptable evidence to include clinical trials of cannabis in other illnesses other than cancer and extrapolate back. So now we get some more hits. We get some hits for some evidence of effect for low mood. Preponderance of trials demonstrate evidence of effect in pain, and some evidence of effect with sleep disturbance. So here are the pain trials. So the first thing to note is it's a very full slide. There are a lot of trials. They're listed chronologically. The ends are small to medium. The length of treatment is usually a week or less. The populations are diverse: MS, HIV/AIDS, post-surgical, diabetic neuropathy, sickle cell crisis, and they're listed chronologically, and you can see that oral mucosal route of administration progresses to combusted, progresses to vaporized, essentially because the research community views vaporization as the wave of the future. They're almost universally positive, with the exception of sickle cell crisis. It did not seem to improve sickle cell pain. But as you can see, that even though pain wasn't improved, mood significantly improved in that population, and sleep significantly improved as a secondary measure in 2 other of the studies. Okay, so now I'm just going to stop for 2 seconds. Does anyone have any questions before I move on? Okay, I'll keep going. So now we're going to move on to the medical community's contradictory stance towards cannabis. So on one hand, we know that healthcare providers are turning to cannabis clinically. How do we know that? Well, because more than 2% of the population of over a dozen states holds a card that had to have been recommended by a provider. Most professional medical associations, however, offer very little clinical guidance around cannabis. Medical practice infrastructure rarely takes it into account. So half of the US is on Epic. That's an electronic medical record. Epic doesn't have an easy way to add cannabis to a medication list. You can very easily report that your patient has a cannabis use disorder, but you can't easily add it to the medication list, even if you recommended it. And some recommending clinicians acknowledge they do not understand cannabis to make the recommendations they're making. I'll explain what I mean in a second. And some patients using it perceive a lack of clinical oversight. So, in a comprehensive cancer center in the state of Washington, where cannabis is legal for adult use and for medical use, 75% of participants in this cancer center wished that their doctors had talked to them about cannabis, but only 12% reported ever having had any sort of information given to them about cannabis. And what's startling about these results is that 1 in 4 was using cannabis. Like, that's not a small amount. Like, 1 in 4 cancer patients was using cannabis during cancer. So this is a survey my group did of national oncologists. So, and what we found was that 80% discuss cannabis with their patients. Almost half recommend it clinically, like try this, but less than 30% feel knowledgeable enough to make recommendations around cannabis. And what was a little curious was that more than half the people who recommended cannabis fell into the group who did not feel knowledgeable. And I think of oncologists as some of the most evidence-based providers out there. Maybe cardiologists are more, but like very evidence-based. So this was a curious finding. This led us to conduct interviews across 8 states with people who had cancer using medicinal cannabis. And what we found was a real lack of medicinal cannabis integration into medical care. Like, it was just sort of ignored. So first of all, most patients reported receiving their certifications to use medicinal cannabis from professionals who are new to their care in the community through brief transactional encounters. All disclosed medicinal cannabis to their medical teams, but they received startling little guidance in return. Participants relied on personal experimentation or commercial information sources, chiefly the cannabis dispensary. And individuals with cancer used cannabis for symptom management, but over half the people in our sample were using it to treat their cancer as cancer-directed therapy, which makes it more startling that they weren't receiving any, advice or counsel to use or not use it for this purpose. And not many were using it in lieu of traditional treatments, like they were foregoing surgery or chemotherapy or radiation to use the cannabis. Okay, so this brings us to suggested future directions. I hope that healthcare providers will verse themselves in the endocannabinoid system. It's as real as the serotonin system, the norepinephrine system. It exists and we should know about it. I hope that cannabis's risks and benefits should be included in medical education and in CME curricula. So I'm so happy to be speaking to you today. I hope that medical support infrastructure will account for medicinal cannabis, that professional societies and medical practice organizations will issue consensus guidelines. And actually, I'm happy to report that ASCO is doing this now. And that we should all advocate for a loosening of restrictions on medicinal cannabis research. But even in the absence of that loosening, we should be carrying out rigorous bench and clinical research on using federal product, like using the federal product that's available, or doing it naturalistically by studying what's happening at the dispensary level, or carrying it out outside of the United States. But most importantly, we clinicians should routinely ask people with cancer about medicinal cannabis and try our best to guide care in this domain. It doesn't matter if you're for or against, like, share that information with your patients. So with that, I'm going to stop and open it up for questions or discussion. I'm so interested to know what you all think.
Thomas, did you want to ask your question? I see that you had a question. Did you want to come on and ask?
No, I
Thank you
didn't.
thank you for the excellent presentation. I was curious, and I'm going to just read my question verbatim. Any thoughts on why in cancer there's no pain benefit, while in other conditions there seems to be some? And my thought would be cancer studies appear to be fully powered, but the non-cancer studies appear to be underpowered. How does that make sense?
Yeah, that's a very, very good question. And actually the smaller studies did show a benefit. Um, I don't know, and I agree with you. And empirically in my experience, I do think there is a pain benefit to cancer patients. Maybe it attenuates over time. Maybe the studies were poorly run. They were mainly done with nabiximols, which is that 1 meter dose spray. So maybe we should be trying it with something else. Less CBD, more THC, I don't know. But it's a very, very good thought. I agree with the power question.
He had another question about, are there countries where cannabis research is possible and thriving? And is there then some, and this is my add-on question, are there then some good, tangible, evidence-based sources of information where we can learn and then be able to pass on that knowledge to our patients who are inquiring about this?
So one of the most inviting countries for cannabis research is Israel, but the research apparatus is underfunded. So people are able to do the research without the red tape issue because the state and the country are one, but there aren't funding mechanisms. So I find that there's not great research coming out of Israel because, most of it is observational anyways. Canada is another great place to do research. I don't know about their funding situation, and I haven't seen any great clinical trials coming out of Canada either. So I wonder if, again, there's a funding issue.
Is there a national cannabis organization that is trustworthy and has good evidence-based data that clinicians can learn from?
No.
Or globally, is there anything? No, okay.
No. It's a very complicated area where it's most of the money available is coming from the industry, and so it's a very complicated place to get unbiased information.
I've got a question for you. Yeah.
Yes.
There's a fair amount of skeptics out there about recommending medicinal cannabis, myself included, for quite some time. And what's the most convincing, or what's the most common skepticism that you've heard, and how do you respond to that? How can we become a little bit more informed about some of that skepticism?
Well, this is a very complicated issue. Because I study this, but I study it without agenda. So it's not because I have an agenda that I think this should be a thing. It's more that it is a thing, and what do we do about it? We're lacking an evidence base. I think one of the things I will point out, which is complicated, is cannabis law has strongly been uneven in the way it affects marginalized populations. So to put this in perspective, I think it's something like in the 90s, 90% of people incarcerated for cannabis offenses are African-American men. And I think like 3 out of 4 cannabis arrests in New York City are African-American men. So there's a way that cannabis law has rolled out that lends itself to bias and stigma, and that affects the kinds of conversations we have in the room. So we know that African Americans are much less likely to report their cannabis use compared to other racial groups. So that's one thing I would point out, that we must all be harboring some level of bias, like latent bias, that we should be very careful to check at the door. And that sort of lends itself to another issue, which is, I don't think this is something that's being taught, that my research has suggested this is not something that's being talked about openly. And as clinicians, we want sort of open discourse with our patients. including our views. Like, I think it's perfectly fine to be not in support of cannabis use, but we should be in support of transparency and even a harm reduction approach to care if it's something you're not in favor of and the patient's going to use anyways.
It feels very similar to me to conversations about like euthanasia. Like my patients will ask me about it, and here in of course the whole US euthanasia isn't legal, but if I was in a physician assisted death state, I would still approach it the same way. It's thank you for asking me about this. Let's talk about it. Regardless of how I feel about it, I appreciate that you're asking me for this information and I can help talk about what's going on.
Yeah, right. Like we want to walk beside our patients and do the best to keep them out of harm's way. And so I think that's what I would say. It's a very important we be talking about this with our patients. That's what we should be working on, but not negating our own views. I saw that there is a question that came in.
Yeah, I can read it for you if you
Okay,
like.
great.
I wanted to echo what you said about Epic not supporting being able to really put in CBD. They let you say it uses marijuana under the other comments, right? So that's an option. And I see that quite often with my patients, but I haven't seen a lot of CBD use or, other ways to classify recreational / whatever they find at the grocery store kind of use. So
Right.
supplemental, for lack of a better qualifier. Thomas says in his cannabis experience, he educates the patients about it along several other medications related to nausea, pain, and appetite. He's mentioning on one hand, it's uneasy to know that in an adult dispensary, there'll be no pharmacist involved. And then he's also agreeing with EHRs. It's a concern that one cannot list the cannabis. Again, that problem comes up, that he can't really list cannabis on a medication list. And then he says concern as a parent is he wonders if this normalizes the use of psychoactive substances, and there is a concern a person is exposed to 300 active substances like you mentioned.
Yeah.
Is cannabis a drug of entry?
I don't know. I live in the adult world. I am a mother of 3, and I agree wholeheartedly that it's problematic. And I have many patients who are using who have young children at home, and I have to worry about diversion. And, I think that's a real risk. And, I think that's a real risk. I live in a state where it is legal for adult use and for medical use. And often the smoke is so thick, it's hard to walk in our parks. I also see some patients benefit. I also see some patients become very ill on it. And I will just share one example of that, which is I recently had a patient who was trying to get ahead of chemotherapy-induced nausea and vomiting, something we know cannabis is good for. So she started chemotherapy, she started smoking cannabis, the nausea got worse, she increased her frequency of cannabis use, the nausea got worse, she increased the potency of cannabis use, nausea got worse, she kept chasing it. And at some point, I began to worry, was this chemotherapy-induced nausea and vomiting, or was this cyclic nausea and vomiting due to cannabis use? And when we finally convinced her to stop the cannabis, she got better. And so that is sort of just one cautionary tale that it's really important that we know, right? Like it's important that we know you're using cannabis, and it's important that we not sort of negate what we're worried about or thinking, but follow the patient.
That's a brilliant example. Yeah, very, very good point that we have to keep in mind, and also encourages us and reminds us to build that trust with our patients so that we truly know what's happening and what they're trying and what is going on in their treatment plan. Yes.
Yeah.
Well, thank you so much. We have to conclude for today, but we are really happy that you were here and sharing this information. Hopefully it'll spark more conversations on this topic in the future, and hopefully we can have you back in the future as well.
Thank you so much.
Pleasure to have you, Alana. Thank you so much for being here. Take care. Everyone have a beautiful Friday. Bye-bye.